Luca and I are going to talk about some strategies for success in building a training program and quality improvement. There we go. This will be a kind of brief overview of how we're going to spend our time together. You're going to see that the majority of our talk, or the majority of this time, will be some breakout sessions to talk about kind of strategies to achieve what we're talking about, which is the devil's in the details there. And then we'll also have some time at the end for just random Q&A and some other kind of miscellaneous things that came up. We'll have some time for a wrap up. So quickly to introduce ourselves. So I'm Ryan Murphy, I'm GME Director of Quality and Safety, and then Luca Boyd is Senior Value Engineer. So both Luca and I work together all the time, working with residency programs within graduate medical education. At least that's what I'm working on with Luca in teaching QI. And Luca now personally teaches how many programs ago? Like 7, 8?
7 or 8, yeah.
So somewhere around 7 or 8 programs where he's actually leading this. And then I kind of also work with some additional programs beyond that in a kind of less intensive capacity. So between the two of us over the past few years, to the point of kind of why are we here, we just tend to notice certain trends, certain things that we've noticed among the different programs. I kind of view this as like the 50 United States, right? So we kind of see how the different states implement things and how some things work better than others, and some places, some programs really strong in one thing, but maybe faltering in another. And so we wanted to share, kind of put together our thoughts about what we think works, what doesn't, and kind of put that into a cohesive kind of presentation. And that's why we're here, to share that with y'all. So I think if there's still only, we were going to do breakout sessions, but if there's still only about 5 or 6 of us, maybe we'll just do this all together. So maybe we can just go in order, and I'm just going to read down the list of names on my end, and maybe just have you guys introduce yourselves, tell us, your role or title, or your role in training in QI, and kind of what you're hoping to get out of this session. So maybe we'll start with Chantal.
So for me, I am a residency director as well in pharmacy, and would like to further develop our quality improvement program. I think the key here is that we've always had quality improvement projects that residents participate in, but I think that we need to really look at it from a more well-rounded perspective. So I'm excited to hear more about the program that you have and how we might build ours up to the next level.
Excellent, great. Steve, you're next on my list.
Hi, I'm Steve Segden. I'm in the addiction medicine, addiction psychiatry leadership, where we work with addiction fellows to in that training type of a situation. They're in charge of IQ programs as well, projects as well. And so this is just trying to learn more about how to gain more insights and to better support our fellows. Thank you.
Awesome, thanks. And Julio?
I'm a professor of biomedical informatics and the associate director for informatics at the CCTS. And we are always interested in improving translational research processes, but we don't have any formal program right now.
All right, fantastic. And then Anna?
Hey, so obviously I've worked with you two before, but we've also got the high value care improvement like pathway within the surgery department that I help run with Bridget, and Luke is part of that too as well. So that combined with my background in program planning just got me really interested in seeing what you put together today.
Fantastic, thanks. And then, oh my gosh, okay, I think we are having a couple more people pepper in here. Okay, so I've got just 3 more. So Jessica, Sorry if you just popped in. We were just doing some introductions, telling us, your role in your area with respect to QI, what you're hoping to get out of this session.
So hey, Ed, this is Jessica Johnson. Sometimes there's more than one Jessica in these things, but I'm in GI. I'm the VA Fellowship Site Director for our program, and we did a couple cycles of some QI, basically looking at endoscopy and efficiency and et cetera. That was pre-COVID, and COVID has exposed a whole other slew of issues. And so I feel like I need just, more help, more ideas, sharpen my skills, bring the A game so we can get back on our toes.
Sounds great. I think we can all sympathize with that. All right, and then last to Maddie. We lose Maddie.
Maddie, can you introduce yourself? We don't hear you if you are.
Sorry, I was talking with it on mute. Maddie Lachey. Sorry, I was just cleaning stuff, so I look really bad, but I'll show my face.
Oh, it's okay.
Maddie Lachey. I am Executive Director for Simulation, and just using simulation for quality improvement for hospital initiatives is our goal in the bigger picture for simulation across health sciences.
Fantastic. And then last but not least, Clinton.
Morning, Clinton Sheffield. I'm the Associate Program Director for Internal Medicine and Pediatrics, and lead our continuity clinics quite a bit. And that ends up being the most common home for our quality improvement projects within our residency program. And so I end up leading the faculty side of resident-led QI projects. And so kind of always looking for new ideas on how to implement QI within our program. We had lots and lots of projects over the years.
Fantastic. Okay, great. This is great. We've got a wide array of folks here. So I count a total of about 6 attendees, but we'll see how this goes. So great. So let's talk really quick about, we're going to kind of share you our perspective of kind of what does success look like for you and your learners. I think we all are under the, we all have different kind of expectations and pressures and availability. And so Luca and I have spent a lot of time about this, and we will speak from the perspective for us coming from the various training programs. We kind of think of success like as this, can learners do these things? Can they look at opportunities to utilize to do QI, right? So like what are those circumstances where really we should be adopting a QI approach, as opposed to just, trying to just do, and maybe adopt a more deliberative approach. And then can these learners then actually apply the principles that we teach in the appropriate scenarios? Can they look at others' approach to quality improvement and assess, how well that's going or what other things could be done, and then ultimately compose a plan for a quality improvement project. You'll note on here, conspicuously, what we have left out is like the actual success of the project. And this is kind of a philosophical decision that we made, but just that, doing enough QI in itself is hard, like most things. And there's always a million different factors that can lead a project to fail. Sometimes it's those that are well outside your control. Luke and I have a number of examples of when that happens. So that's why for us, from a learner perspective, we're like, look, we're going to take them on through a training program. At a bare minimum, we want to be able to do all of these things. Now, if we actually have this project and we can lead it to implementation and it gets this new process and we get this new outcome and this happens over time, like, awesome. And like, I think that should be like the goal for everyone. Like, ultimately, that's what we want to do, right? Like, we want to change things. But personally, we have found that, especially within the circumstances of our programs, our GME programs, or especially in light of, say, a global pandemic, sometimes we're not always able to achieve that. So then at a minimum, then we want to make sure we're at least making this a good learning experience and focus on the learning. One of my like teachers in QI really emphasized that. So like, look, some of your projects are going to fall apart. You're going to get 2 steps into your 6-step process, and you're going to realize like the project doesn't work, or something else is going to come up. So again, we just really emphasize that from our perspective, we really try and focus on the educational piece of it, because no matter what happens with the project, at least at the minimum, learns all of that.
Hey, Ryan, let me jump in here for a moment and make a comment, because some of you guys provided some great insight about what your roles are in helping residents complete a quality improvement project. And I hear that a lot. And so I wanted to clarify that very briefly, that for a resident or a medical student to complete or participate in a quality improvement project, you don't need a quality improvement program. There are many sources and opportunities to be involved within hospital and clinics or health sciences for residents to partner up with somebody and do a project. What Dr. Murphy and I are going to be talking about today is the next level up. Now, it's how do you leverage XYZ, which we're going to talk about in a moment, so that you can build a learning experience that is experiential, and it's something that the residents are going to take away with them beyond just the project, and how your department can work together successfully. This is our definition of success, so that the learner, the resident, is participating in a project, but also learning social skills, leadership skills, communication skills, presentation skills, all these things to help build this packet. And for that, you need a program, in my opinion. So just wanted to throw that in there.
Yep. Oh, thank you, Luca. All right. So we've noticed some common barriers and common kind of challenges to success among programs. There are many. These are just a few, but maybe some of these will ring true for you all. But so little support or buy-in from key stakeholders. So again, you're trying to do a project. It's rare that we're able to do something in this tiny little microcosm of that small group that we have control over. You know, you're going to have to collaborate with some folks. We see sometimes people have just kind of an unstructured approach to QI, which is exactly what Luke is getting at. Like, if you just want to hop on a project and get involved in some project, you can. But you know, there's lots of things going on in the university, but to go through it in a structured manner, and realize the benefits of that. Big one, right? Limited time and resources. I've had programs come to me and they say, I literally one program said, we wanted to come talk about you know, QI patient safety, and I had about 6 minutes. And then another one that gave me an hour. You know, so you know, everybody's working within their own you know, within their own kind of boundaries and limitations. But that is a common one, and we can talk about that. And then I think a big one that's challenge to success, and this comes from, we see this a lot with our learners, just bias from negative prior experiences, right? So I can tell you from the GME perspective, there are, you know, the requirements from our kind of accrediting body from ACGME basically say that we should be involved in QI, and they kind of leave it very vague. And so people can kind of check a box towards the very end of their training on a project they throw together, and it doesn't have a lot of meaning for it, and then that's what they think QI is. So lots of just different challenges to success. Okay, so how we're going to go about this? This is the bulk of what we're going to talk about here. Strategy, our different strategies for success. We've got kind of these 6 different domains that we kind of have identified, and then at the end we'll have a little bit of miscellaneous potpourri, some kind of like smaller scale questions and things. But we're just going to go through this one by one. I'm going to turn this over to Luca to talk mainly about, as we go through these, talking about each of these areas and giving you an example of things we've seen in our programs that we have found successful. I will throw out there that these things, it sounds great for us to say, oh, just do this. I will recognize that every single one of these things is very hard to do, and we're hoping that that's where some of the discussion among us in this group here, we can start to talk about what are some of the barriers to that, and maybe learn from each other about what other people have done in other programs to achieve these things. And so as we go through this, please, again, enter questions in the chat. If you want us to address them, we can, if it's relevant, we can address them as we present, or we may kind of move that towards the end, like I said, for that kind of miscellaneous um, series of questions we'll have at the end. But yeah, and then also, if something's really important, feel free to interrupt us. It's a small enough group. We can answer your questions. Okay, so I guess I will turn it over to Luca here, and we're gonna start going, we'll kind of go through each of these one by one, but we'll start with leadership support.
Yeah, and also wanted to add one quick thing about one of the challenge that I hope that residency programs are realizing is that over time we are starting to see an increased number of residents coming from medical school that within medical school they've already had exposure to quality improvement projects, and so they want to be involved also within they will want to be involved here. So when I started teaching quality improvement to residents 6-7 years ago, there was very little understanding of quality improvement from their end. Now, about 50 to 60% of residents in a class that I teach, they already have done a quality improvement project. They speak the language, and they're just looking for an opportunity to do more. So that is why understanding these strategies and trying to implement them the best you can within your department really is going to help. It's going to help the residents to have a positive experience and continue to hone their skills on quality improvement, but also help the program itself, because of course you're going to have you're going to see improvement in quality because of this work. So leadership support, there is a reason why this is the first one we talk about. And just to clarify, because I was thinking about this earlier, I don't just teach residents quality improvement principles and tools. I also help leaders in the program try to figure out how to make it a better experience. And one of the main things we talk about is leadership support. Do you have your department chairs involvement? Do they participate? Do they talk to the residents about it? Do they make time and so on? So this is an example that came up and it just worth sharing. For years, these programs learners struggled to identify projects they could engage in. Once the department quality leader became involved in the quality improvement training program, again, this was a person that was very passionate about quality improvement, but I finally had the leadership role within the program. And they started identifying or helping the residents identify projects or areas of improvement that were also important to the department. One of the criteria or indicators for a residence program or any a residence project or any project to be successful is that it has to be important to the individual, to the team, but also important to the department. So in this case, the department's quality leader helped identify and prioritize the project. It would be beneficial for both the learners, but also the program. This is how leadership should support the QI program, help prioritize and help identify projects that are meaningful to everybody. Next.
And I'm sorry, I forgot to mention, so we'll talk about these in pairs, and then we're gonna have some time for the breakout. So, and if you look at the attachment or the file that we put into the chat, it's going to have all these questions that we're going through. So you can feel free to open that, use it as a worksheet, or just kind of refer to it. So for this was the question we had.
Yeah. Do we want to? Yeah. Another one is faculty. Right. In the breakout sessions, if we're still going to do them, we'll have time to talk about, ask those questions to each other, and then report out. Faculty mentoring. Many times, especially in the past, not so much now, I was the coach and people just brought me in and I was the person trying to tell residents how to do a QI project. That works up to some degree, but I really don't have the experience and know-how of what is going on in the department, the culture of the department, which is very different from program to program. So for faculty, I like the concept of the dyad. I can help provide the coaching and the support. I or anybody else can help provide the coaching and support on the tools and the principles, but to help drive the program, the project itself, it's so helpful to have a faculty mentor. And how does that work? Well, like in this case, you have a program that had gone through several versions of the QI curriculum for the trainings. In the current iteration, the residents meet monthly as a single group with dedicated time focusing on one large project. And we are all working together. We're talking about one, or in this case, sometimes it's two projects, but the faculty member there is the key. They occasionally look at me for solutions or for ideas, but the team of the residents now is well aware and comfortable in asking the faculty members, which are always present there, to provide, asking their perspective, what is important to the institution, and help them prioritize the next steps. And most importantly, faculty also speaks quality improvement language. So they are able to talk and transfer the department, the knowledge about the department, but also make it applicable in terms of the quality improvement training we're trying to provide. Next.
Sorry, now I'm speaking muted. And so here are again the kind of questions that we'll use in these sessions. I'm going to share a couple of thoughts that came from our group. Everyone agreed that having the faculty involved is really important. There's a couple of barriers. One, having faculty be, so having this clinical faculty be available is hard. So in terms of time and resources, and we're going to talk about that in a moment. The other thing that came up that Luca and I definitely run into a lot is the faculty themselves may not have a lot of either experience in QI or knowledge in QI, and they tend to end up steering our learners towards doing research, which is a very common problem, and that's a whole larger discussion because there are incentives to do that that are different from the incentives to do QI. The small plug I will throw out there is that we do have training for faculty that aligns with what we do at the university to learn QI, and we have in-house training that is free. To some degree, it's asynchronous. You can do it whenever. If you want to do it in a more organized fashion with some discussion, collaboration, then that's something we can offer once a year as well. So again, I will encourage you guys to reach out to me and or Luca afterwards. You'll be like, hey, I want to get, or I have some faculty who want to get involved, but we just need to increase their exposure to what QI is and how to do it. So with that in mind, I'm going to share my screen again, and we'll pick up on the next session. And again, I'm sorry, as this always goes, we never have enough time, and so we always have to cut conversations short. Okay, but we'll go on to the next one, the big one, time and resources. Luca, take it away.
Yeah, and this is not just time and resources for project is not just having a dedicated 1 hour session to do a didactic discussion. This is literally, some projects take more than others, and residents need time to go observe, need time to collect the data, need the contacts that would help them pull the data and so on. So a program has had a successful quality improvement program for several years. The work is centered around work in an ambulatory setting. That definitely helps being in an ambulatory setting. Once a month, clinic is shut down for half a day. Faculty, learners, and all clinic staff collectively work on QI project. Again, that the resources that are working on the project are all there. They're all talking about the project. They're working together. Meetings have prepared agendas. There is a structured progress, and everything takes place within that half a day. The work progresses that half a day once a month. This is a very specific program. Some of you may recognize it, who they are, but obviously many programs can't shut down for just half a day. But it's just, we share this example because it demonstrates that what is the department's commitment of what can be made available so that the resources and the teams and the residents can work, can collaborate, can work together. So, next.
So again, questions to ponder on that. We'll go to the next one.
Yep. Didactic resources. One program went through several different iterations of education in quality improvement. Earlier iteration involved didactic lectures with instructions for learners to lead individual projects. Later iterations, which were most successful, focused on guiding learners through quality improvement project with incorporation of didactic throughout. So this one is interesting to me because I have also been part of building this curriculum that has evolved over time for many different programs. And one thing that we've learned is that there is nothing wrong per se. Many programs just go through the history of quality improvement and go through various iterations of explaining what quality is, what patient safety is, and then hopefully give time to the residents to work on a project separate, independently from those lectures. With this specific program, we started piloting what if we used that project idea to teach quality improvement. And so the sessions became the project meeting. And so now the team is learning how to do a process map. Okay, now I'm gonna teach you to do a process map. So that is, we flipped. Instead of using the time we're doing these didactic sessions to teach about quality improvement, we use them to meet and talk about the project, and it's working out very well.
Right. So again, you all can think of the kind of flipped classroom approach as kind of that idea, and kind of a hybrid of the two. Okay, we have 25 minutes total left. So we can, let's do maybe 5 minutes on these two, and then we can come back and do the last session. In the interest of time here, I think I'm going to share this kind of last slide, and we're just going to quickly kind of talk to a couple, like we said, kind of miscellaneous points that we have seen or questions that have come up, and then I think we'll use this final time for folks to ask questions, either of me and Luca or of the group, but just a couple specific miscellaneous things that have come up across different programs that we worked with. So should my learners work on a new project of their own choosing? Oops, sorry, share again. There, can everybody see that? Okay, great. So, should my learners work on a new project of their own choosing, replace an existing project? There are pros and cons to each of these approach. Basically, in general, we see that most trainees want to pick the project they work on, but as some of you noticed, if they work on something that no one else cares about and it's not clinically relevant, it's going to be really hard to get that project going. It's really going to be hard to get buy-in. Similarly, if we just force a project upon our trainees, then maybe they're not going to be as super excited. So I personally think the approach is to try and have maybe a small selection of projects that are quote unquote, department sponsored or favorite projects, and kind of try and urge your learners to take one of these projects on, and really sell it to them. Like, look, you're gonna be able to support, you're gonna be able to do a lot more. That being said, if a learner really is fired up and they really want to do their own thing, like by all means, great. But we might need to focus on maybe it's being more of a learning experience again. Another thing that comes up is the program is small and does not have the resources for kind of resources and infrastructure that we've all been talking about here. And again, this is something, there's not a ton of time that we can all talk about this together, but some strategies that we have seen are, so multiple divisions within one department will kind of pool their resources together, and we can kind of so that's one approach. We in GME we have a bunch of fellowships that maybe have 1 or 2 trainees per year, and so that can be a little more challenging. Again, I think part of this is a process, but if you or anyone you work with finds you're in this situation, again, reach out to me and I can talk in more detail. How we approach this really depends on the specifics. And then the last one, this already came up in our small group discussion. I don't know if this came up on yours, Luca, but we talked about learners end up doing a research project, right? So we have this time for QI. We go through this, we have all these didactics, and then we like meet with the learners and we talk about what they're doing. And we're like, wait a second, like you're doing research. This is not QI. Is that okay? Again, a larger discussion, but our kind of approach is, and this is something we were working on with a couple of programs, is going back to the kind of the heads of that program saying like, look, we're happy to come and talk about QI, but you guys are not doing QI here. And this is how to do that. Again, I think that's the role of having the clinical leadership and having faculty who understand what QI is and have gone through some training. And again, that is a struggle. Okay, sorry, I have Julio, I love your I love your comment, and boy, you're preaching the choir. I agree. Maybe we'll get into a true like a capitation model or some sort of model where we actually have to do QI, and it isn't just an academic exercise.
This will be like in the was like late 70s, 80s when the Japanese cars were dominating everybody, and the big three took quality improvement very, very seriously. When it's a matter of survival, then the guys that are the bosses will really take this seriously. Hopefully the University of Utah would be at the frontier and be prepared, but I don't know.
Okay. No, I totally agree. I could have a very long discussion about that over some.
And this is very, very important also on for things like the Clinical and Translational Research Institute, because what in translational sciences we call the T4, which is really spreading the innovation to practice and stuff like that, is still the weakest link in the system.
Agree, totally agree. So sorry, we've got 5 more minutes. I just want to reference a couple more things. As we were preparing this, we did find some if folks want some more, some other reading. Here's a reference that speaks to a lot of the same things we had. I actually kind of personally disagree with some of the things, or I have a spin on some of the things they recommended. But this was another good reference, and that is our kind of prepared content. We wanted to leave a few minutes here at the end for just some, again, additional questions or thoughts. And again, here's our contact information. So any other points that kind of weren't addressed or things we wanted to talk about in these final few minutes? And again, when we do run out of time, reach out to me and Luca. And if not, maybe then I'll give Luca any final departing thoughts.
Quick question on the 5-minute videos that you mentioned earlier. Are those items that would be available to share with our preceptors and residents going forward? It would be lovely if that were sort of put out maybe broadly across the university as some educational points for those of us who maybe struggle with time and how we fit that into a busy schedule.
Yeah, so absolutely. So Luca has some lovely videos that we worked on and put this in GME, but I don't see any reason why we can't share that more widely. Luca, any thoughts or comments on that?
I just was going to say they are not studio professionally done. They're just me talking and pontificating on quality improvement principles, but they're just, I think, to serve a purpose. Many videos that I find on quality improvement, and they drag on and they are difficult to follow. And and I think that just sticking to some very basic principles, like the way we've tried to do it, it has been helpful. So one commentary I was going to leave you with then is the fact that, and I don't know if it was clear from the sessions, I'm gonna specifically state it. What Ryan and I have found is that programs that follow most of these strategies in their programming to teach their trainees quality improvement are likely to see residents learn and adapt quality improvement principles in the residencies and later on. And I say later on because even after some of these student learners, residents went through these programs, eventually they call back, they email back asking for additional information and support to continuously do quality improvement in their throughout their career. So it's okay to just tell residents to do a quality improvement project, because it's okay, I'm being ironic here. It's okay to say, hey, Ryan or Luca or Gwen or Chantal, can you do a 1 hour session on quality improvement with patient safety and calling it a day. But if you are serious in trying to implement a quality improvement program that produce replicable results, these strategies are what you should be aiming for. Those are really the true north for helping you meet your ACGME criteria.
Okay. Gwen, you want to wrap us up?
Yeah, I want to thank our presenters, Ryan and Luca. Thanks so much for a very interesting presentation. And again, reach out to, for those of you who participated, thank you, and reach out to Ryan and Luca if you have questions.
Thank you all so much.